By the people, for the people, the gathering to get healthcare now. Chapter 8. A startup independent physician association must support 5 people and an office and equipment for about 2 years before earning enough income from administrative fees to operate in the black. The burn is about $500,000 a year. If the IPAs are organized into 5 teams, each team consisting of 30 primary care physicians and 30 specialists, and each practice commits to $30,000 of capital in the form of a note payable over 60 months, the IPA will have a stable capital balance that will allow it to contract favorably with health plans. To think there are no contingencies and no need for this level of capital is an unrealistic expectation. When the insurers require a letter of credit deposited with their health plans to have a contract in which they would share profits, the IPA will need about $1 million to get off the ground. Fortunately, times change, and there are bargains in the current market. The $1.8 million in notes from participating providers will enable the letter of credit. Once the IPA owners have committed their seed capital of the $1.8 million without debt and show that they can produce bonus income from global capitation agreements with CMS, with HMOs, and with commercial insurers, then substantial added capital can be raised from private equity firms. Selling 40% of the shares in the IPA management company will raise about $6 million per IPA and give a return of 10 to 15% per year to the investing company. The basis for additional capital is the profit the IPA can make in the future from reductions in cost from the payers, which are by contract shared with the IPA. The fat in the Medicare and commercial insurance premiums that can be cut are from misuse of facilities, drugs, diagnostic procedures, and from uncoordinated care. IPAs have been able to do that in Medicare Advantage programs over the last 30 years and can do it in other kinds of shared savings agreements with CMS and commercial insurers. Sometimes the percentage of savings that will be shared is restricted to 10% of the gross premiums, but not always. It's possible to contract for as much as 86% of the gross premiums for the professional and hospital pool and to retain all of the savings. You must take all of the risk and post all the reserves when you make those kinds of agreements, but the margins can be well worth the risk. When 86% of the average gross premium is $9,500 per year, increasing each year, by the way, patients and the fat portion of that 15% when the potential gross profit is $1,400. This kind of profit has been made many times in Medicare Advantage plans. Half of that amount is about $700. And when you raise capital selling 40% of your futures, then you could get 6 to 7 times $280 per person because of the shared savings contract. At 6 times, that would be $1,680 per patient. Most IPAs could qualify about 2/3 of their patients for this kind of investment. The idea behind this kind of capital infusion is to make each practice in the IPA capable of employing the labor and technology required to achieve savings. Their sacrifice is to agree to let the IPA represent them exclusively in contracts with third-party payers. It is as if they were professional football players and had gotten a signing bonus for agreeing to long-term contracts while playing the game to the best of their abilities, where those abilities were well known to the owners. The professional football comparison is very interesting from a financial perspective. For example, An NFL player roster is about 53 players. A local medical service organization is about 53 participants. Coaches in the NFL, 15. Managers in the local MSO, 3. Administrative staff in the NFL, 10. MSO, 9. Gross revenue in the NFL franchise, $600 million. In the MSO, $800 million. Operating income, $250 million in the NFL, $265 million in the MSO. Salaries, bonuses, and overhead, $150 million in the NFL, $120 million in the MSO. Net income, $100 million in the NFL franchise, $145 million. Market values, $1 billion for the NFL franchise, $1.45 billion for the MSO. When you compare numbers, it would seem investors would prefer a highly performing medical group to an NFL franchise. There are certainly fewer barriers to entry with the medical group than with the NFL franchise. Also, the selection of the medical group should probably be done using a selection process as good as that used by professional football teams. Pick the very best players that can perform well as a team. Recruit them early, help them along as they're learning. In other words, play medicine ball.